43 of Idaho's 44 counties face a physician shortage problem. I mean, there's a reason we're last in the nation for doctors per capita, right? And it's a state of scarcity we didn't slide into overnight. And sure, we've seen a surge in people moving here, but not enough of them have been primary care physicians or doctors. It's a problem that the governor, medical leaders, and local health operations are trying to figure out. First step, form a special committee. Second step, a meeting of said special committee. And on the agenda, what's causing the problem? What are the solutions from other states? And what realistic goals can the Gem State set? Joe Paris listened in.
Data in recent years, really dating back decades, shows that the state of Idaho is struggling in the medical sector. Idaho ranks 50th in the nation for physicians per capita, 49th for active primary physicians.
We've got two incredible forces that are impacting Idaho: rapid population growth and aging physician getting out of healthcare.
Idaho medical education leaders and lawmakers are now developing an ambitious plan to address the state's severe physician shortage. The State Board of Education's Idaho Medical Education Plan Working Group. A big question looms: how many doctors are really needed?
I've often been stunned when I've worked the math in that we could bring in roughly 1,500 additional physicians just today, just to get us to the national average of active physicians per capita. So the number is so big.
Dr. Tracy Farnsworth is president and CEO of the Idaho College of Osteopathic Medicine, ICOM. Like other leaders, he's looking for ideas across the country.
We just need to move and with due haste in all these ways. And by the way, I have some friends in West Virginia at their schools of medicine that speak very admirably about the incredibly creative things they've done and are continuing to do.
West Virginia is a place that the working group is studying. They have dramatically improved their doctor-to-patient ratios through aggressive investment and incentive programs.
They also have targeted loan forgiveness, so they maintain multiple incentive programs for students and trainees who are willing to live in state. So medical student loan program offers up to $10,000 per year in loan forgiveness for students who commit to practice in primary care or other needed specialties in underserved areas. The Health Sciences Service Program offers a one-time, roughly $30,000 loan repayment to new graduates who match into primary or emergency medicine residencies in West Virginia.
And I really resonate with the West Virginia model, quite frankly. And again, as you've pointed out, they kind of have a multi-pronged attack. They were using loan repayment, scholarships, and UME seat expansion.
Dr. Ted Epperly is president and CEO of Full Circle Health. He is focused on developing graduate medical education in Idaho, things like residencies.
It's going to take some loan repayment mechanisms, which we're starting to do quite a bit with. Something we've not done is scholarships on the front end, loan repayment on the back end, some UME expansion, some GME expansion, and all of a sudden Idaho's going to start looking even better than West Virginia.
But at the center of it all, there needs to be a target. What is the actual goal Idaho is working towards?
Do we want to be 49th? I mean, what is the metric we're actually looking for here? Just something better, or is it an actual target? Is it 49th in the state? And so then what's the math that you need to do to get there? To that target. And I don't know what the right answer is. I mean, I would like to be less 50th.
A clear goal is so important, and a soundbite is powerful. So as I listen to this discussion and I hear what's being said, the stake in the ground is we want to be at 25 out of the states, at least 50% of what the national average is. And if that number is 1,500 new physicians added to our force, whatever that number is, I think that's a way for us to all start visioning what it's going to take.
And all of this is really hinging on paying for it. In another part of the conversation, here in Idaho and across the country, Medicaid. Because, did you know, Medicaid is the second largest source of funding for GME, and that is basically the graduate medical education, so residencies or fellowships for specialized training across the United States. Places like Idaho, they can fund those GME programs through Medicaid. So Brian, when Medicaid cuts are now another factor that Idaho has to take a look at, it's another hurdle. We also know that with only so many slices of the pie, so to speak, in terms of state dollars and federal dollars, paying for ideas like a state-sponsored medical school is complicated. Dr. Epperly, though, did point out, though, that through the big, beautiful bill, the state of Idaho could get between $500 million to $1 billion between now and 2032 to help pay for some rural medical things. However, it's hard to set all these programs when you don't know your funding source and you're also trying to catch up based on decades of growth.
Rural medical things, I don't expect that includes paying doctors to live in places they may not want to live.
That's true. I mean, if you say, hey, you know, we can get these doctors special incentives to come to places like rural Idaho and work in residencies and then commit to being in a place for 3 years, that's one thing. However, if there are not the medical facilities or the tools that they feel they need to be successful in those areas, it's another thing to add on top. Developing new medical centers, making sure they have the latest technology.
Right.
And a lot of this, too, is going to count on Medicaid, Medicare, and federal dollars, which are being impacted, whether you disagree with it or not. They're being impacted in a way that to do the math and figure out what you need is very complicated.
Yeah, and it's worth pointing out these bigger hospital systems like St. Luke's are also rural hospitals because those who live in rural parts of the state have to go there to see a specialist that they might need to see.
Yeah.
So it's all part of that. All right, thank you very much, Joe.